We have next on our list Dr. Rishi Swarup, a charming young man with admirable surgical expertise, and let's hear his pearls of wisdom. On to you, Dr. Rishi. Namrata would have to give us an extra grace time if we are going to have longer discussions.
We have another one, Chitra. Anyway.
Dr. Rishi, can you stop for a minute?
Rishi, we can't hear you.
Dr. Rishi, can you stop sharing? Dr. Rishi, can you stop sharing?
You have to unshare your presentation, Rishi.
Rishi, are you muted?
Yeah, but sir, Dr. Rishi, when you share screen, just click share sound on the left hand side bottom. The extreme left checkbox. Share computer sound.
So I click on share screen and yeah, share sound. Okay, got it.
Now sound will go through.
And optimize screen share for video clip.
Not required, sir. Not required.
Okay. Is the screen visible now?
Yeah.
Yeah.
You can see my video?
Yeah, yes. We do. Yeah.
Okay. So I'm just going to give you some tips on how to improve your visualization in opaque corneas. I'm a cornea specialist, so this is my area of interest. Now, I'm just going to give you a few simple tips. One is, often we have these opacities on the cornea. Of course, this opacity is not very irregular, but sometimes you have very bad irregular surfaces along with the opacity, and just putting a small dispersive viscoelastic dollop on top of the cornea can significantly improve your visualization by smoothing the surface. So smoothen the surface with a dispersive viscoelastic. I think this is probably the biggest tip that I'd like to give. Keep an endo illuminator in your cataract OT very, very handy, irrespective of whether you're anterior segment or posterior segment. It makes visualization of every step of cataract surgery much easier. You can see this patient with Steven Johnson with such a bad cornea. You can't see a damn thing in coaxial illumination, but the moment you start putting a endo illuminator, everything inside the eye is visible. It can help you on every step from rectus to nucleus management to cortex aspiration to vitrectomy if you need to do one, or if you have a desmus detachment, it can help you visualize the desmus. So all structures in the anterior segment can be seen very well through any sort of an opacity if you use this kind of a light. You can even put the light inside the anterior chamber through the side port and help visualization better. So here, you know, the visualization looks like you're just seeing a regular cataract, but once the endo illuminator stops, you'll realize that there's quite a dense central corneal opacity there, through which operating with a stereocoaxial illumination of a microscope would not be very safe. So you can see, once the light goes, you'll realize that the opacity is quite dense. You know, so this is it. I think the biggest tip that I would like to give you when you're operating through an opaque cornea, keep an endo illuminator handy. Third is, be generous to use stain. Any case where the cornea is not perfect, please stain the capsule, because it will help you see the capsule very, very much better. In this case, of course, we also have a small pupil, so we have to enlarge that. But using stain will help you not just for the rectus, but also in subsequent steps when you're trying to manage the nucleus. You can be sure that you're not catching the capsule at any time or injuring it accidentally. So, of course, there's nothing great in how to stain the trypan blue, but just wanted to make a point that use stain. So, make the surface smooth by putting a viscoelastic on top. Use an endo illuminator. Here again, you can see there's a dense spheroidal degeneration, but putting viscoelastic suddenly improves the views. Final tip to improve your visualization is that the epithelium is usually your friend, but there are some final conditions in which the epithelium is very opaque and irregular. For example, this is a patient with a gelatinous drop-like keratopathy, and you can see the surface is very hazy. And the moment you remove the epithelium, this patient is a post-deep lamellar keratoplasty, but there was recurrence to dystrophy in the graft. So he needed a cataract surgery. Along with that, we've just done a debridement of the unhealthy epithelium. You can see the view improves, and because we removed all those nodules, he also had a very good visual improvement in his vision because of removing the surface irregularities from the subepithelial layer. So seeing well intraoperatively will also help your patients see well both better postoperatively. It's important that you see what you're doing. And these are just some small tips that I want to share. Thank you.
Thank you, Rishi. There are one or two small things to be added, as you depicted very beautifully. Maybe keeping on putting dispersive viscoelastic to improve the magnification. And sometimes these are cases where you could even relocate your incision based on the location of the opacity.
Yeah, I didn't go into any of that. This was just to improve your visualization. I mean, there's so many things which come into play: IL calculation and enlarging the pupil. Yeah.
No, visible. The other thing is, while doing phacoemulsification, you could remove one fragment and get a better red reflex than instead of doing all your chops. One or two small things I thought you could add, but wonderful.
Apart from that, the use of the chandelier illumination, you showed about this using it endo illuminator outside, but we have experienced with putting it through a sclerotomy. That gives a beautiful retro illumination. The second thing is, instead of debriding the epithelium, we have found that soaking in glycerol, a pledget of cotton or even Merocil sponge, and keeping it on the cornea for some time really cleans it up.
That works if it is an edematous cornea. These were not edematous.
If it is an edematous cornea, then in that case, this also works quite well. And of course, if you have a keratoconus and it's irregular cornea, sometimes visualization is very poor. In those cases, putting a contact lens, I mean, we even saw recently a contact lens of the patient himself being put on the eye to improve visualization. These are few more things that could be done.
One very important
few
point,
more things.
While staining the capsule in these cases, you should not by mistake put any drop over the cornea. And secondly, you should have a large air bubble underneath so that you put the dye underneath the bubble. The best way is to put the viscoelastic and then inject the dye under the viscoelastic. Otherwise, what happens many times, these opaque cornea, they take up the dye very easily and your visualization may reduce because of the dye.
Another point is the use of proper illumination when you're doing such cases. If you have a mature cataract, then it's better to switch to an oblique illumination, because if you're using a stereocoaxial illumination, the glare is too much when you're doing your capsulorhexis. So for mature cataracts, I switch to oblique illumination and visualization is much better. And if you have some amount of glow, then if you switch to a stereocoaxial illumination, even if you have some opacities on the cornea, then your retroillumination is much better. Of course, your microscope is going to be expensive. Yeah, like the Lumira 700, and then you can easily do a.
Dr. RP, I just wish to slightly have a different view. If you actually put viscoelastic first into the anterior chamber and then try to stain, the stain doesn't come. So if you have to protect the backside of the cornea or the endothelium, you have to put a bubble of air and then inject the trypan blue under the air rather than use a viscoelastic and do that.
I think what sir meant was use of sodium hyaluronate, sir, not HPMC. Sodium hyaluronate, under that you can actually stain it well, sir.
No, any viscoelastic will not give you a good deep stain.
What is it? Tri-soft staining. Tri-soft staining, like you put the stain under the visco. It takes up very well. I've done many.
Only sodium hyaluronate, it works well, sir. That's what I have done.
Okay, I will try, but the best thing is to put an air bubble and below the air bubble, and that gives you a better pressure onto
the air. What happens? The dye would come anteriorly to the air also. Like very easily they come anteriorly.
Anyway, I just wanted to make a point, and this second thing that I wish to say is that at times Rishi, you have explained almost everything. You left out my favorite chandeliers, which Ram pointed out.
I don't have that.
so anyway, the other thing that I just wish to say is that there has been instances where epithelium was edematous and the person was just removing it, and it was basically the LASIK flap which got amputated.
Yeah.
So that has been described. So basically, VR surgeons at times just are pretty aggressive in removing the epithelium. So just be very sure of the history of a laser vision correction done. And
your valid point.
Yeah.
One small trick.
Yes,
if there is I agree with my pulsar that when you put viscoelastic and it's a hazy cornea, it doesn't kind of stain. And trypan blue would be taken up by the corneal endothelium only if it is diseased. Otherwise, it doesn't become. Otherwise, if it is not a disease one, if there's just a scar present and it's kind of healed, then it is not going to take up the trypan blue dye.
Yes, it entirely depends on the type of viscoelastic that's being used, as Rajendra Prasad was trying to point out. if it is cohesive viscoelastic, if it is heel-on, you can stain under that. You can inject under that, and they don't mix. But if it is HPMC, the whole thing is going to become a granular mess.
You just have to brush over the anterior capsule slowly.
No, it's okay for normal corneas, but for hazy corneas, it doesn't work that well because the staining always, which is under a viscoelastic such as heel-on, is never as dense as when you stain it under the bubble.
And not uniform.
Yeah.
Dr. Swarup had something to say?
Yeah, one small trick which I use sometimes is that many times these opacities, they have certain areas which are clearer, and we can use parallax. So we can tilt the eyeball little bit and see through that area. I think that also helps in some.
Good point.
Thank you very much.